For the next presentation, will be by Binoy John. Actually, Binoy John is currently the director and head of cardiology in a famous hospital in India. He is also the invited faculty in TCT, GCTP, and CCT. He has been in interventional cardiology for more than 2 decades. So today he will give us a talk on bypass graft PCR.
Okay, good morning, chairpersons, panelists, and dear friends. At the outset, I'd like to thank Dr. Lam and HKCCI for this invitation to this prestigious conference. My topic would be bypass graft, angioplasty, or in vitro. So, the common bypass grafts that are used are the saphenous vein grafts and the internal mammary grafts. Coming to saphenous vein graft, angioplasty, SVG degeneration is unique and different from native coronary stenosis. The SVG blocks are large, soft and friable, lipid-rich, with large necrotic debris, and they often lack fibrous cap and calcification, and often have overlying traumas. Atherosclerotic blocks start appearing in the SVG 1 to 3 years following a CVG surgery, and the degeneration increases thereafter with time. So, what do we do? PCI or redo CVG? Which is better? Redo CVG is associated with high risk, morbidity, mortality, and risk of damage to a patent lemur. This makes percutaneous intervention a good option compared to redo CVG. However, SVG angioplasty is associated with a high risk of distal embolization and slow flow, no reflow phenomena. Therefore, highly degenerated grafts and CTO is best to target revascularization of the native coronary artery. So the mechanisms of slow flow. Manipulations during angioplasty causes fragmentation of these plaques, which causes the release of chemotactic mediators, platelet and leukocyte activation, release of vasospastic mediators like serotonin and endothelin. These three mechanisms result in a triad of microvascular thrombus formation, microvascular embolism, and microvascular spasm, resulting in the slow flow phenomenon. Coming to SVG angioplasty, it constitutes 3 to 5% of all PCI and is associated with 5 to 20 times more complications than native PCI. The predictors of adverse events, the strongest predictors were the lesion length, associated CKD with a greater than more than 1.5, and any CPKMB rise. Even minor increases were associated with an increased 1-year mortality, and when CPK elevation occurred more than 5 times the upper limit of normal, there was a 1-year mortality increase from 4.8% to 11.7%. So, simple cases can be complicated by poor planning, and similarly, complex cases can be simplified once you understand the nuances well, along with better planning. So, I will talk about tips and tricks of SVG interventions. Tips on guiding catheter selection: grafts which arise from the outer curve of the aorta, as per RCA, you can use Judkins right or IR. So this is a Judkins right being used for an SVG graft to RCA. And this is an AR1 in SVG to the PLD of RCA. And when you want to tackle left bypass grafts arising anteriorly or for the LAD and diagonals, you can use JR or left coronary bypass catheter or a hockey stick. And for grafts on the inner curvature, as for LCX, you can use AL or hockey stick. So this is a JR 3.5 being used for an SVG to OM2. And tips on embolic protection devices. The most dreaded risk of SVG angioplasty is distal embolization, and slow flow incidence is 10 to 15% of SVG PCI. Distal embolization is associated with a 31% risk of MI and is associated with a 10-fold increase in hospital mortality. Dual antiplatelet therapy is warranted, and GP2B3 inhibitors have no role in elective SVG angioplasty except in acute MI involving the graft, as debris are mostly atherothrombotic than thrombotic. Distal embolization can be decreased by the use of embolic protection devices, and it is a class 1A recommendation by ACCA AHA to reduce the risk of slow flow. And it is always best to use an EPD unless in low risk lesions like aorta osteo lesions and distal anastomotic lesions. The currently available EPD systems include the distal occlusion balloon, of which the example is a Percusage guard wire, and the distal filter, the Spirex, and proximal protection devices process. I will not be going into the details because of lack of time. So filters are better than balloons, occlusive devices, and 80% of the debris are less than 100 microns, and digital protection devices like filter-based EPDs have a pore size of 100 to 110 microns and helps to prevent microembolization. The spider X consists of a wrapped filter in a sheet, and it also has a capture wire onto which the filter is attached, and it is covered by a sheet. And the advantage of this filter is spider is that you can use the wire of your choice for crossing the lesion. And tips and techniques on filter placement. It is important to use a filter of appropriate diameter. The filter should not be too wide or should not be too narrow. This is a 4 mm spider effects filter being used in a smaller diameter graft, and this is a 5 mm spider X in a larger graft. Steps of filter placement. So you have a workhorse wire on which the spider X sheath is set. Now coming to tips and techniques of internal memory artery interventions. IMA lesions present as either stenosis or kings. Stenosis or IMA is rare and mostly occurs in anastomotic sites as a procedural complication. So kings of IMA have been reported as rare cases in literature, and king is a sharp bend in the body of the IMA, and it can occur from twisting or looping of the IMA, and it can be dynamic, sometimes disappearing with deep inspiration, and can produce significant ischemia. The case which I am going to show is a Lima king, which showed significant ischemia on stress myocardial perfusion imaging in a patient who presented with angina, and it disappeared after the angioplasty. So you can see this is a king. There's a whitish shadow just at the bend, just below that stent. You can see there's a circumflex stent there. So this was a case which I have done in 2012. And so coming to the intervention, knowing the IMA characteristic is key in performance of a safe PCA. Ostial dissection can occur, and it is important to avoid deep throating of the guiding catheter as it can produce ostial dissection. A second wire can sometimes be passed into the left subclavian and prevent deep throating of the guiding catheter. And IMA is highly prone for spasm, and flow may cease after wiring, producing no flow, ischemia, and infarction. So here the guiding catheter has been engaged, and IMA grafts are often long and tortuous, and hence wiring can be difficult, which needs longer wires and longer shaft balloons. And shorter guiding catheters, 90 centimeters, can be used from the transcranial approach. Guide extensions can be used for support, and hydraulic wires are useful in tortuous matter. So, hydraulic wires and tortuous Lima can cause antegrade cessation of flow and by spasm, kinking and pseudo lesion by the accordion effect. There can be pseudo kinks, and sometimes kink transfer also can occur when you use the wires. This makes visualization and positioning of balloons and stents difficult. And coming to stent length selection, long stents are easy to use, but the problem is fresh kinks or pseudo kinks can occur in the lower segments. And short stents are ideal, but difficult to position when the flow is obstructed by pseudo kinks. For anastomotic site stenosis, balloon angioplasty is preferred, and stents are avoided as there is high risk of restenosis. So here you can see that I have passed the wire, but there is no flow seen. That is because of pseudo kinks and spasm which is occurring because of the wire. And so when I withdraw the wire, you can see again that the Lima is filling. In such cases, external markers like Lima clips or bony landmarks and stents present can be used as references for positioning. Here I am using an artery process as an external marker to locate the kink. But in this case, this is for demonstration, I use that circumflex stent as a reference to position my stent. So here the stent is being positioned. I did a shot after pulling the wire actually. And once I was convinced with the position, I deployed the stent. And this is one of the shots, and this is the final shot, and the kink has disappeared. And there are no pseudo kinks because I chose the shorter stent. And so this is the final result. So coming to the take-home message, SVG addiction rates can be up to 15% in the first year, and only 40% of the grafts are patent by 10 years. The higher risk morbidity and mortality associated with redo bypass surgery and damage to the patent Lima makes angioplasty a preferred option for revascularization. SVG angioplasty classifies as a complex intervention, and strategies and techniques are different from native coronary artery angioplasty and as SVG or venous conduits. Vein grafts more than 3 years are more degenerated and have a higher potential for distal embolization. EPDs will help to prevent distal embolization, and vasodilators can be used in the treatment and prevention. And stents are best sized 1:1, and oversizing is to be prevented. Should not be done as it can produce extrusion of other material. Oversizing of the stents can also result in perforation, and restenosis rates are much reduced in tests, and they are superior than covered stents and VMs. Coming to IMA angioplasty, IMA is prone for dissections and spasms. They are tortuous and prone for pleural lesions, and King's cancer is a major issue to be remembered in tortuous lima. And in spite of all these confounders, safe completion of both SVT and lima interventions are possible, and a repeat CST can be avoided in high-risk cases with a sound knowledge of graft behavior and interventions. Thank you.
Universe, much too big to say.